we go with temperature today. First of all, few definition. Core temperature. Our core temperature usually range from 35.5 and 37.5. This is the normal core temperature that we want to aim usually lah in a normal person with a plus minus of 0.5. So it can go from 35 to 38. Okay, that's why in ICU we only take it at 8.3. Anything no, with lower temperature in the morning and higher in the evening. So there are two different definitions for hypothermia. Hypothermia in a normal patient, as a patient is in ICU or patient in the ward, and something called perioperative hypothermia, which is by NICE guideline. This is the temperature measurement that we want to aim or we classify in a patient going for a op or patient who just finished a operation in surgical. So these are two different things. Hypothermia in a patient who are not planned to go for op, not in a perioperative period. Perioperative hypothermia, the patient who are immediately going for a surgery or intraoperatively or after surgery. So the numbers differs. As you see, in a patient with hypothermia, only below 35 degrees Celsius, we tell them it's hypothermic. Whereas in a perioperative patient, 35 to 35.9. Also, anything below 36 is already considered hypothermia. It means the perioperative hypothermia lists higher temperature as hypothermia. You know, they are more strict in classifying hypothermia because intraoperatively you will lose heat more. So we want to make sure the temperature control is more rigid. So hypothermia in general, like in ICU and everything, we say it's less than 35 degree, mild, moderate, severe lah. This one you can read. Then anything less than 28 degree is severe hypothermia in a patient who are not going for op. Let's say patient who coming with initial phase of drowning, sea drowning or freshwater drowning. If the temperature is less than 28, we call them severe hypothermia. But in a patient who plan for a surgery, let's say a patient is planned for a anterior perineal resection, APR, or patient going for major surgery, ripples, or any surgeries. In that patient, nomothermia is, we want to aim 36.5 to 37.5. See, the range is just 1 degree Celsius. Whereas the range in a normal patient core temperature range around 2 degrees Celsius. So perioperatively, they are more strict. So periop hypothermia, anything below 36, we consider patient as hypothermia. So a patient coming for an op must come in a temperature above 36 before you start the case. And before you discharge the patient from recovery, you must make sure patient is above 36 degrees Celsius. That's why we always concerned about temperature control in the OT. Then periop hypothermia, look at it. Anything below 34, we already say severe hypothermia. Whereas in the normal situation, less than 28, see how much of the gap. Because in a perioperative period, hypothermia is serious complication in the outcome of the surgery and also in a systemic complication as well. We will go in detail. So next is hyperthermia. Hyperthermia is in general, not perioperatively. Perioperatively, we are not concerned about hyper. Perioperatively, we are concerned about hypothermia. So hyperthermia, as I mentioned, you say in a normal situation, 38, but in ICU, we are talking about ICU setting, 38.3, then only we take it as fever. Hyperpyrexia is more than 40, life-threatening is 41.5. So this is for MCQ purpose. So few definition you have to know. One of it is thermoneutral zone. So these are the few first definition. Second is thermoneutral zone. What is thermoneutral zone? Thermoneutral zone is the ambient temperature range over which nomothermia is maintained without any changes to basal metabolic rate. A simple example. When you are feeling cold, what you will do? You will shiver. Shiver is increasing metabolism. There's increasing. So when you shiver, you are producing heat. The heat will increase your core temperature. That is one of the auto-regulation, means thermoregulatory mechanism, compensatory. Okay. Another one is, let's say you're feeling hot. When you're feeling hot, what you will do? You will take off your clothes. You will expose yourself, or you will. So this is this will cause your heat to be lost. So these are the basal metabolic rate changes, whatever that changes your basal metabolic rate. But ambient temperature is the temperature which during this period there not much change in the basal metabolism. It means lowers oxygen consumption to maintain homeostasis. During this ambient temperature range, there won't be much alteration in the basal metabolism. For a naked 70 kg male, that mentioned as 27 to 31 degrees Celsius. I'll come to this later. Okay, you have to remember, for a naked 70 kg male, 27 to 31 degrees Celsius is the temperature range where lowest oxygen consumption is required to maintain the homeostasis. Remember this. Another definition that you have to know is interthreshold range. So this is my own notes on temperature regulation and homeostasis in 2 pages which I scribbled. I've explained in detail later So I want you to look at it here. The one that we looked at it just now is thermoneutral zone. Range of ambient temperature at which basal metabolic rate and oxygen consumption is minimal and steady. You all can see the arrow, right? My cursor, right? If you all cannot see, just let me know. Otherwise, I'm just going to continue. So thermoneutral zone, range of ambient temperature at which basal metabolic rate and oxygen consumption minimal and steady. And adult naked 70 kg male is 27 to 31 degrees Celsius. In pediatric is 32 to 34, infant 34 to 35, neonate and peds is 32 to 30. Usually the peds age is actually higher, but in case of infant, it's even higher. In neonate, it's similar to peds because they have a lot of brown fat. Please go up and read on Carrie Brandy's and podcast after this my lecture, so you all understand better. Next is critical temperature. What is critical temperature? Critical temperature is lowest limit of thermoneutral zone. In case for adult male, lowest is 27 degrees Celsius. For pediatric, lowest will be 32 degrees Celsius. That is critical temperature, can come out in MCQ. Next important is interthreshold range. Okay, interthreshold range is range of core temperature over which no autonomic thermoregulatory response occur. As I mentioned just now, during this period of range of temperature, you don't have to do anything. No autonomic symptoms or no compensatory mechanism to occur. So the temperature alteration can be adjusted. Okay, in a non-anesthetized adult male, non-anesthetized patient not going for op, let's say in ICU, or patient who are at home and a normal presence, is 37 degrees plus minus 0.2. It means 36.8 to 37.2. It's very short range. You see, very short range. Okay. But if the patient under general anesthesia, this range will actually widen. It means it will take longer time for compensatory mechanism to occur. Why this range in a non-anesthetized patient is short is because it's very important to maintain the temperature within this range. So whenever the temperature goes below 36.8, your body will compensate either by shivering, increasing the basal metabolism, causing vasodilatation and all these things, vasoconstriction and everything. If the temperature is going 37.2 and above, it means temperature is increasing. The body will try to lose the heat to bring back it to 37 in a non-anesthetized. This compensatory mechanism is lost in a patient who are general anesthesia, under general anesthesia. So when a patient in a general anesthesia, you see the range is widened, means 37 minus 2.5 is 34.5. If the range becomes 34.5 to 38.3, it means if the temperature go above 38.3 only in intraoperative period, a patient with general anesthesia will respond. The autonomic system will respond. And if the patient hypothermic, they have to go hypothermic until 34.5 before the body can compensate for the heat loss. So that is the important. In general anesthesia, the autonomic response in thermoregulation is the threshold has been lowered and heightened. So it's a wide range. So patient have to wait for, patient actually will suffer a significant complication before actually it can compensate itself. So far, I think hopefully you all can understand this part. Okay, we'll come back to this whole thing again later. Another thing, your temperature regulation. Who control your temperature? You don't have to know in detail about the anatomy. Remember, anterior hypothalamus is involved in heat loss. It means if you're having fever, your anterior hypothalamus will get stimulated and it will bring out the autonomic system to causes heat loss. Okay, that is anterior hypothalamus. Okay, what about heat gain and set point. Let's say you are losing heat, which part of the hypothalamus will get stimulated is posterior hypothalamus. So posterior hypothalamus will do all the compensatory mechanism to gain back the heat and reset the thermoregulatory point. Okay, remember this. Okay, I will come back to others later. Okay, that's all about it here. Okay, next, thermoregulation. A core temperature in the blood, if it's increased, a core temperature is increased, which hypothalamus will get this one? As I told you, anterior hypothalamus, because you have to lose the increased heat. So anterior hypothalamus will get started. It will initiate all the, it will stimulate the heat loss center. The heat loss center will cause all the mechanism to reduce the heat by causing vasodilatation. When your blood vessels are vasodilated, the vasodilatation will cause heat loss to bring back the temperature lower. Decrease metabolic rate. Sweating, you will sweat more. When sweat, you lose the heat. And hair is lowered. You don't have a goosebump lah. When you're cold, you get goosebump. Why you have to goosebump? You increase the surface area to capture the heat. But when you fever, the hair will be lowered. But in opposite, if the patient having hypothermia, core temperature is reduced, heat conversion center, it means posterior hypothalamus will get activated and it will bring about autonomic compensatory mechanism, as in vasoconstriction. When vasoconstrict, less heat being lost. Increased metabolic rate. Metabolism are exothermic reaction, mean they produce heat. When you shiver, you actually increasing your muscle contraction. When muscle contraction again exothermic reaction. Air race, goosebumps. So goosebumps reduces the heat loss. It captures the heat loss because when you all the airs are raised, goosebump, you have actually increased the surface area. Explains over here. Okay, please read up on this. Okay, that's about it. So when you want to know how this thermoregulatory mechanism occurs, you have to have three main things. One is the sensor, one is the effector, and the middle is the controller. Okay, your sensor is your receptors, your peripheral receptors that will find out about your sensory heat sensation or temperature sensation. Your controller is your hypothalamus. Your effector is either the sweat glands, your skin, your air follicles, and your muscles. All these are your effector. Effector means what bring about the compensatory effect. Okay, so your receptors, you have to know, this one can come to an MCQ. The receptors that detect warmth is Ruffini, which is C fibers. Cold receptors are called Krause. Which nerve fibers they go through? C fibers and A delta fiber. This is purely for MCQ. So just when you do MCQ, if you found, you go back, refer this, and then find out. And then the compensatory mechanism, what can happen? You see, by shivering, you can increase your heat production by 5 times. Non-shivering thermogenesis, because your metabolism your muscle can contract with shivering. That's why patient, you see, when they're cold, they will have a shivering, rigor. So rigor can happen in a patient who are too cold or too heat. What happen when they have fever and then they're having rigor? Because fever is peripheral temperature is increased, but core temperature is low. That's why patient is shivering. When shiver, you increase your heat production by 5 times. Non-shivering thermogenesis only increases your BMR by 2 to 3 times. But shivering thermogenesis, heat production 5 times. What is the disastrous effect of it? Shivering thermogenesis, you increases heat production 5 times, means you're increasing your oxygen consumption also. This is good, not good in a patient who are already hypoxia. Okay. And then in a patient who have a increased temperature, the vasodilatation will cause increase in blood flow to your peripheries, your cutaneous and muscle blood flow. It will increase 30 times more blood flow to the peripheries. As the temperature go higher and higher, the blood flow to the cutaneous part also go higher and higher. But when the patient have a cold stress, increase in cold to gain the conserve the heat, vasoconstriction happen. Vasoconstriction does not occur more than a tenfold, because too much of vasoconstriction, you're reducing peripheral perfusion, and it's not good because aerobic metabolism won't occur. Because when you reduce your blood flow to an end organ, you're actually reducing oxygenation. and you switching the aerobic metabolism to anaerobic metabolism. So it's not good. The vasodilatation will increase 30-fold, but vasoconstriction only reduce 10-fold from the normal blood flow to the patient. Okay. Again, you see increase in body temperature, increase in blood temperature sent by hypothalamus. The blood goes to the hypothalamus, will detect it. Anterior hypothalamus. Anterior hypothalamus will, this is the controller. This is the effector, the sensor, the receptors and everything. Then this is the controller. Controller center is activated. Then blood vessels in skin dilate, swell gland activated, decrease in body temperature. Then sudden decrease in blood temperature, again posterior hypothalamus is where the heat gain start. So skeletal muscle generate heat, shivering begins, and blood vessel vasoconstrict. So this is a cycle. Again, I've mentioned here. So what are the things that involve? One is vasoconstriction, mean blood vessels, shivering or sweating, your air follicles, and then your own behavioral responses. Either in a patient who are cold, what you do, you put on more clothes. Patient who are actually heat, what you do, you take off your clothes, or you expose, or you stretch your body, because when you stretch your body, you increase your body surface area, a lot of heat can be lost. Understand? So that's all for initial beginning of temperature regulation. So I want to show this is a difference in a patient who are non-anesthetized and anesthetized. You see, when the patient is non-anesthetized, because all your anesthetic agent, either IV or inhalational, all causes peripheral vasodilatation. When there's peripheral vasodilatation, your heat has always go to pressure, whatever. It also go from high heat to low heat. It transfer. So your core temperature is always a higher heat, more warm than the periphery. So in a non-anesthetized patient, the core will be always kept warm. But in an anesthetized patient, when the peripheries are dilated, vasodilated, your core temperature will be lost to the periphery. That's why your core temperature will come down. Okay, because your periphery compared to your core, you always lower than your core. So core temperature will come down. You see core temperature drop. So this is important in anesthesia. So again, this is what I mentioned about interthreshold range. Okay. This part, interthreshold range, this part. Okay, you see in non-anesthetized, the range is smaller. In general anesthesia patient, the range is higher. You see that here. This is the interthreshold range in awake patient, 37 plus minus 2. Anything more than 37.2, sweating occurs, heat loss. Vasodilatation occurs, heat loss. Anything lower than 36.8, heat gain occurs by vasoconstriction, non-shivering thermogenesis. Anything goes below 35.5, shivering thermogenesis occur. But you compare with the patient who are anesthetized. For a sweating to occur, patient have to go up to 37.5. And for a vasodilatation occur, patient almost have to reach 37.8. Okay, so this is the difference. We go back again to this. You see, it's 34.5 to 38.3, the range. Next, here you see in a patient who are hypothermia, 35.5 only the vasoconstriction occurs, whereas here 36.8 already vasoconstriction occurs. And then at 35, non-shivering thermogenesis, and you have to wait until 34 for the shivering thermogenesis to occur. Please go through this and read this part and then try to understand it. Anyone doesn't understand, always can WhatsApp me. Okay. And then hypothermia complication. This is purely for you to read up and understand. There's nothing much to explain. This is from what I've read from CACCP and ATOTW and Kerry Brandis and podcast. I've summarized and I've put it into system by system. Okay, this is simplified notes, my own notes, and there are a lot of different notes. So I combine it and did it simple. Hypothermia, morbid cardiac outcomes is increased 3 times. Surgical site infection increased 3 times. 20% increase in blood transfusion also needed, because hypothermia causes coagulopathy. Coagulopathy causes increase in surgical blood loss. And then for CNS, what can happen? Read on this. Sometimes can come out. And CVS, what can happen? I've summarized. And then ECG changes in hypothermia also I've summarized here. And RS, renal, all this you all can read yourself. Okay. And again, complication of hypothermia and hypothermia can read on your own. This part again, ECG changes in hypothermia and bradyarrhythmia. What happens lah patient hypothermia? This is just for reference in case when you do MCQ. Okay. Okay. Next, heat loss during intraoperatively. What happens? How the heat loss happens? There are 5 main process where heat loss occurs. RCER is the important one. I remember as Royal College Exam Room, which is the mnemonic given in the podcast lah. Royal College Exam Room. Okay. The fifth one is called conduction. This is very minimal. It's not so important. So we put it as 5. This 4 is important, and then the percentage given in each group can differ, but we take it as simple as 40, 30, 20, and 10. You can forget this 5 also, I don't mind. 40, 30, 20, 10. 40, 30, 20, 10 will come to 100. But if you want to remember exactly, it's 40, 30, 15, 10, and 5. Total is 100 lah. But if you don't remember this, you tell me it's 20 and 10 also, I'm okay with it. Okay. So it's radiation for R, C for convection. Convection first, not conduction. Don't get mixed up. Convection comes first. Vection. Okay. How I remember, again, I use my name lah. B comes first lah. D will always later lah. B always comes first. Something like that lah. So radiation, convection, evaporation, and respiration and conduction. So what is each of it? Radiation is the thermal radiation emit from the body. Mean your hot mean the heat is like a thermal exposure. Okay. So if you look at it, radiation, right? You look at it, radiation is your thermal exposure. I'll show you. Your radiation, you see, radiation, thermal exposure emit from your body. Okay. It depends on temperature and color of its surface, different between body and room temperature. Let's say your body is 38 degrees Celsius, your room temperature is 27, you will lose the heat. That's why we have to maintain a certain room temperature, cannot be too cold. You see, when a pediatric patient comes, what we will do? We will make sure the temperature of the OT is warmer than the normal patient. You cannot keep the patient room too cold because the heat will get transferred. Okay. The one that highlighted, I put here is how you want to reduce the methods. Please ignore this for now. I'll come back to it later. So that's about it. Convection is transfer of heat away from object. Okay, you see. Convection, again, it is away from the object. It means it does not depend on the room temperature, you know. This is actually, if you look at it, occurs when the layer of still air adjacent to skin is distributed proportional to the square root of airspeed. It means just immediately above your body surface or around your body surface, if there is a continuous airflow going in, which is let's say it's a cold air, then your heat will transfer. That's why what we do in a patient coming for OT, we put a warming blanket. We want to make sure the airflow just above the patient or in contact with the patient is also hot, so there's not much of heat loss. Okay. Next is we talk about evaporation. Evaporation, I think you all know, it's like a water vapor. Latent heat loss from evaporation. Heat taken away from the body for the process. Moist area open on surgery. Let's say it's an open area, patient will lose the heat via the vaporization process. Okay. So evaporation. Okay. This is evaporation. Okay. Then finally is respiratory loss. You all also know the evaporative loss, heat loss, bronch breathing. And finally is conduction, transfer heat between two objects, contact down gradient. That's why we always put a layer of linen cloth on your patient, between patient and the OT table. Because the OT tables are metal, rubber, they can be more cold. If the patient patient body is in contact with the cold object, they can also lose heat. Okay. So this picture you all can see here, again here. The air movement, all this important lah. You can read this part of this definition later. So important part is how we gonna reduce the method, how we gonna reduce the loss. How we gonna reduce the heat loss by radiation is by making OT temperature is optimal, not too cold. Insulate the patient. That's why we wrap the patient, right? We always wrap the patient with the autobahn or anything. Give them warm fluid. So when you give warm fluid, what you're making? You are making the cutaneous blood flow is quite warm. Okay. And we put a radiant warmer. Okay. We put a radiant warmer underneath the patient. Okay. Next, convection. How do you want a convection? As I say, you will put a forced air warming blanket. This radiant warmer is overheat. Mean overheat warmer like for pediatric, because we want to radiate the heat. Okay. Is always you see the radiation. Okay. But in a convection, we put a adjacent airflow just above the patient body, immediately above, okay, the blanket. Evaporation, how we maintain evaporation? We don't simply expose the viscera. In a patient who are doing laparotomy or anything, whenever they are not operating, they want to take a break, go check the X-ray, CT abdomen, we ask them to close the abdomen. Don't keep it unnecessarily open. Okay, expose viscera covered in plastic bag or aluminum foil. Avoid unnecessary exposure. Warm irrigation fluid. That's why when they want to wash the abdomen, they don't use cold saline. They use warm saline also. Okay, that's important. Respiratory loss, how we lost? HME, you all know that. Low gas flow circle system with soda lime, because you want to use the rebreathing. You don't want a patient respiratory exhale breath which is formed to get eliminated into the environment. And finally, conduction, as I mentioned, avoid cold metal objects contact, use warming mattress and remove wet linen. So these are for exam and also your work purpose. During your work, you are working, you are doing a case, you should remember all these. Okay. So this part of it, again, you all can read. Please read podcast. Podcast explains it in the. Okay, next you want to know how is the heat loss process occurs during a general anesthesia. How is the process? So it has a phase 1, phase 2, and phase 3. Phase 1 occurs within the first hour. You see, let's say patient comes, how much it occurs? It occurs due to you give IV induction agent, you put in a patient with this is patient general anesthesia, you start your gas, immediate peripheral dilatation, vasodilatation occurs, and distribution of core heat to periphery. Average drop 1 degree Celsius in the first hour. You see, it dropped in 1 degree immediately. Then after that, phase 2 is gradual heat loss, because after your peripheral vasodilatation occur, your core temperature is lost to the periphery. After that, it tries to equilibrate. So the loss is more linear over time. Okay. So it goes like this. Next is your steady loss. After some time, your body controller is your hypothalamus trying to compensate the mechanism. Your body heat loss matches your heat production. It comes to a plateau, which only occurs after 4 hours into the surgery. So most of the operation lasts only 1 to 2 hours. You see, within 1 to 2 hours, patient can lose almost 3 degrees Celsius. So if you're patient, if you start a case with already hypothermic patient like 35, 36, 35, patient will lose another 3 degrees, they'll go into 32 degrees, which is a severe hypothermia in a perioperative period. And patient can have multiple hypothermia complication as I listed before. That's why we always want the patient on the hyperthermic side, 37.5, 37 at least. Okay. So when they don't lose much, and we always warm the patient and we actively do all the measures to prevent this heat loss occurs. This in a patient who we are not taking any active method to prevent the heat loss. This is in a patient who we are not taking any active method, and this how they will lose. Okay, next, comparison between general anesthesia, comparison between a neuroaxial block and a patient with a combined general and neuroaxial anesthesia. In a patient who only have a neuroaxial block, it means patient with a spinal or epidural, you see the heat loss is much lower. Okay, this again phase 1, phase 2, phase 3, you all can read as I mentioned. Next, in a patient with general anesthesia, as we already spoke, and if the patient have combined general and neural anesthesia, we do a combined GA epidural, because epidural will cause vasodilatation because sympathetic blockade. On top of your GA also cause a peripheral vasodilatation, and patients lose more temperature. So what is the best way in a patient? If they ask you what type of anesthesia technique is best to prevent hypothermia in a patient, of course in a sole neuroaxial block or peripheral nerve block or anything. Then next would be your general anesthesia. GA and combined epidural is the least preferred. Okay, remember this graph. Again, this is a summary of it. Remember it. Again, as I mentioned, these numbers can vary. If for me, in my because you see these numbers add up, won't come to 100%. So remember as 40, 30, 20, 10. That's more than enough. Convection comes first, and conduction not important. Respiration, then only conduction. Conduction comes last. We follow textbooks. Conduction comes last. RCER, Royal College Exam Room. Always remember that. And the C is convection. Conduction is the least important one. Okay, methods of warming a hypothermic patient. Again, I've mentioned here, I mentioned the methods according to the heat loss. But in another general way, you can say non-invasive and invasive. Non-invasive, ensure patient's skin is dry, they are not wet when they come, not a wet linen on top of their body, the baju is not wet. Cover the skin. While we do, we rape with them with the towel and autoban. Cover or close the wounds, don't need unnecessary exposed. Raise the ambient temperature and mean OT temperature. Make sure a radiant warmer, overhead warmer is placed. Force 8 warming blanket is placed. Invasive, we give a warm IV fluid. Luminal lavage, in that sense, patient was very cold, we can give a bladder lavage warm fluid. Hemodialysis, hemofiltration is another way, but we don't. And cardiopulmonary bypass is the ultimate method in a patient going for bypass, TABG and everything. When we want to warm up, we warm up with them, warm fluid going through their heart and the whole systemic circulation. Okay. Again, patient, let's say a patient come with 37 degrees Celsius, peripheral temperature 31. You are not warming the patient. No pre-warming. Anesthesia induced vasodilatation. See how much patient lost. They can go up to 34 degrees Celsius at periphery. But if you pre-warm the patient before you give him your induction drug, that's why very important, patient comes in, before you give your induction drug, put on the warming blanket on top of the patient body first, at least for a few minutes while you are preparing a patient. Once you put on your monitoring everything, put on the warming blanket first. Don't immediately give, and then once you settle into bed, anchor, then only want to apply the warming blanket, because at that point of time, patient already reach here, and then from here for you to come back here, it will take longer time. Okay, this is next is strategies for prevention of intraoperative immediate perioperative hypothermia. IPH is, this is from NICE guideline. This is extensive. This is for final master's notes from a NICE pathway, NICE guideline, which is very, very good, but too much for finals. But this is good for your exam work purpose. When you free, please read this. Okay, all this, the highlighted, everything very good. Before op, what you're supposed to do, during and after, and this is the explanation of it in detail. Okay, next we go to temperature measurement. I will end this and then I'll start another session, less than a minute.